Next we go on to Dr. TITIYAL, who needs no introduction, and he's going to be talking to us about his top pearls for toric intraocular lenses.
Thank you, Dr. Ramamurthy, for kind inclusion in this very, very interesting instruction course. Good evening, friends. Every step of surgery can be pearl, but I would like to summarize this in three different zones. One is looking into a preoperative pulse, investigation-wise, diagnostic-wise, and second would be taking you to a surgical pulse, and third will be a post-op management pulse. So let me take you through the initial investigation, patient selection for these cases. We all understand if you are putting a simple monofocal lens, anything more than one diopter in corneal cylinder should be corrected. If you are going for a multifocal, trifocal, or a EDOF lens, even less than 0.75 may need to be corrected in these cases also. These are cases where your toric lens may not work effectively. If you look into that, irregular astigmatisms with a corneal scar, corneal ectasia, glaucoma drainage devices, prior vitreoretina procedure, poor pupillary dilatation, or there is a posterior capsular dehiscence, jonular instability, which Rakshit talked about. These are poor candidates. If you have poor ocular surface also, that needs to be taken into consideration. Manage that first, then go for other cases also. Just showing the biometry of one of my case. This is a patient came to us for a simple monofocal posterior chamber IOL implantation. If you look into biometry, patient has a significant cylinder of 2.4 diopters. So definitely this patient has to be counseled for a toric IOL and it should be considered. This is a patient came for a premium IOL and looked for a trifocal IOL for this patient. But cylinder, if you just look into total K, 0.76 diopters. So normally you might disregard this in a normal manual phacoemulsification surgeries. But looking into this patient requires, if you go toric calculation for this patient, requires a T3 implantation of our trifocal lenses. So it's a very significant to look into your biometry very, very carefully and discuss in a various presentations also. Biometry should be the first investigation in a virgin cornea so that you don't disregard that. This is what we talk about, TFL stability, look for a grade of cataract in difficult situation, stabilize the ocular surface. But looking for axial length, nothing better than optical biometer if you have that. If you don't have that access, then look for a second option can be immersion biometry, which can be as accurate as possible. Keratometry or corneal power mapping can be done various instrumentation, but make sure whichever instrument we use that should be well calibrated, and that is very, very important thing. Calibrated equipment should be there. Even you use optical biometer also. Always try multiple measurements to enhance the accuracy and look for two important areas. If you have a similar steeper corneal meridian in these cases by 2-3 devices, you have a better cornea. That means patient doesn't have irregular astigmatism. The magnitude of toricity may differ a little bit, but if your axis is matching, that case is a suitable case. See, this is a biometry being done by my technician. This is not accurately placed into fovea. Even a patient still can give you a lot of cylinder. So this patient shows around 2 diopter cylinder, which is not correct. So if you have proper centration, you can see the well centered, the fixation up to fovea, and you see the corneal mire right on the center. So those things will also be checked by the patient. Patient having a poor ocular surface. See, these mires are distorted. This tells you that your cornea is not stable at that time. Put 1 drop of artificial tear or do it after half an hour, the readings will be more accurate. In fact, this patient doesn't require the toric IOLs. Always look for the anterior corneal curvature, which may be against the rule or with the rule, but we know that posterior corneal curvature is always against the rule. That make a difference in the final calculation. See this biometry here. If we would have taken only the anterior corneal curvature, this was 0.89. But if you see, because the anterior is also against the rule, the actual correction is 1.18 diopters. You would have undercorrected this patient as such, especially for a multifocal, trifocal lenses. It has to be taken into consideration. See this, from T3, 0.5 diopter residual. If you go a T4, 0.02, that is the difference which makes. The other important criteria is how to measure posterior corneal curvature and which type of instrumentation are required, and this is the various tools which can give you a various assessment. If you don't have instrument which can detect the posterior corneal curvature, you can go through various nomograms which tells you that what would be the posterior corneal curvature in these cases also. IOL power wise, always take those calculations or those power formulas which takes into consideration posterior corneal curvature, effective lens position, apart from the other areas of these concerns also. If you have access to a higher intraoperative abnormality, that may be helpful. What are the pulse I like to suggest here? For implantation IOL power, selection should be within 1 diopter or so. If you are going multifocal, less than 0.75 also should be considered. Any device which takes into consider posterior corneal curvature, a better device. More accurate devices are the biometries which takes into consideration OCT data also. Formula wise, always go for a formula which takes into consideration posterior corneal curvature and the effective lens position also. There are various formulas available online that can be a good way to look into. The second area is the surgical consideration, which you all have been doing very effectively. I think measuring the corneal astigmatism, steeper axis is very, very important, and putting a marks on the cornea is also very important. So you can do a manual marking, you can do image-guided surgeries, or you can have intraop abrometry. That can all be effective in these cases also. So this is an image-guided surgery which I am showing, which gives you a regular area of incision always, and also give you a guided rhexis orientation also, so that your effective position of lens can be placed better. Because it is important to have a uniformity in making rhexis also, and these guidelines are always better. Many of you may be doing a marking on the cornea, and that also can be satisfactory. Surgery should be simple so that you don't damage the posterior capsule. Once you clean the posterior capsule, implant the lens. Idea here is to not to leave any viscoelastic. That is one of the important tip to taken up. Go underneath the IOL, don't worry. Remove the viscoelastic, then place the lens in the desired axis and hydrate subsequently also. These are open J-loop haptics. Sometimes they rotate when you hydrate it. This is one example. I'm removing the viscoelastic here. This is my axis of orientation, 111 degrees. I place a lens quite accurately now. You can see it is right accurate here. Now I'm hydrating the wound. By this time with the hydration, the lens would shift. So this is shift, clockwise. So this lens cannot be rotated anti-clockwise. So that's why there's always a tip. Keep your lens little anti-clockwise when you are doing the hydration manipulation, so that you can shift the lens clockwise, which is easier also. Manual marking should be, very sharp. I think that is very important tip which people might miss. And if you have these three markings, 3, 9, 6 o'clock, the orientation is better. And if you have a sharp markings, your lens placement axis will not deviate much. If you have a fuzzy, hazy margins, things can be difficult also. But if you compare manual versus image-guided seems to do better. Especially this is useful in cases where you are implanting trifocal EDOF lenses, which will be very, very important to have a very accurate orientation with your lenses. To give us some pulse in this, manual methods are good. If you have a pendular markers, accurate positioning can be done. Image-guided is always better in terms of giving you a better quality of vision with your trifocal, multifocal lenses. Intraop abrometry, if you have, it's a good adjunct to difficult cases like a post-refractive surgery patient, where sometimes the corneal biometry can be tough in those cases also. Last bit on how to look into a post-op alignment. These are predisposing factors. And most importantly, your accuracy might change because lens might shift in a post-op period. Within a 1 hour, seem to have a maximum rotation in these cases. If you leave viscoelastic, rotation will be there. How to make a decision in these cases? Which cases might benefit by rotation? So this is a simple analysis. The rotation may not help if you have a spherical equivalent more than the cylindrical error. If you have a cylindrical error, which is more than a spherical equivalent, this patient is going to help by rotation. See here, the spherical equivalent -2 diopters, but the cylinder is one diopter only. You can correct this only. You can't correct the spherical equivalent because your initial calculation was wrong. But if you see here, spherical equivalent 0.5, but your entire other area is more. 1.5 cylinder is seen there. This is the patient which will benefit by rotation. And before that, look for a visual acuity uncorrected, perform refraction, show the refractive cylinder now. dilate the pupil, see what is the new orientation of lens and what was your corneal cylinder. That is the rotation required for this patient also. You have various softwares which can guide you to rotate and how much correction can be done with these also. This is one device I use regularly, iTrace, which looks into enhancement software, gives you how much rotation is required and how much correction can be done with this. And if you take the patient, rotate, and subsequently you get up, this is the post-ops, 1 degree rotation, no rotation required, good alignment. To summarize the important points in a post-op check in a toric IOLS, check for a toric alignment. If you have rotation more than 10 degrees, less than 6/9 vision, you might have to take patient back to OR. And these are various ways you can check the rotation. Look for various formulas which can give you a better way to judge your patients. And realignment should be done within the first week or so. But if you have a larger bag, you might wait for some more time. And especially in those cases, you might have to take with the image-guided surgery again for second time. This is a review article in IGO. You can read and gives you all the details. And thank you again for listening to this talk. And thank you, Dr. Ramamurthy, for giving this opportunity.
Thank you, Dr. Titiyal, for that wonderful exposition of the entire array of toric intraocular lenses. My go-to formula for my basic IOL power calculation is the Barrett toric calculator, because I straight away upfront I want to know whether toric is indicated or not, which takes into consideration the posterior corneal astigmatism. It's not universal too, but toric calculator.
Absolutely correct. So normally what our standard ways to go for a universal first, but whenever we are going for a patients requiring EDOF or a trifocal, we always say go for a toric formula right from the beginning. That tells you exactly what is the current scenario for that patient. Good point.